Welcome to the series 2 of the Melasma files, and we are now at a different location over here, very serene water and Hooghly river which is there in front of me and Dr. Day. So doctor, we were talking about lasers. There are many practitioners in a daily practice who cannot, you don't have lasers. So what kind of peels, chemical peels are the treatment for melasma? Where do which kind of peels do you use, and what is the kind of response do you have? Is that a long-term treatment for melasma?
Yeah, I would say, even if you do not have lasers, the buck doesn't stop there. There are other modalities of treatment. Chemical pills is definitely one of the best modalities, and still is one of the workhorse in my practice. I would say you can choose a lot of chemical pills and you see there are specific melasma pills are also these days, but if you look at the literature, then the best possible evidence for pills in melasma are either on TCA pills or glycolic pills. Of course, there are other pills which has been tried, but the better quality evidence is with the TCA pills and the glycolic pill. Now, talking about the pills, I'll tell my the junior colleagues that quality of pills is extremely important to get a good quality result with the undue side effect in treatment of melasma. So while choosing TCA pills, I usually prefer two brands. One is from SkinTech company, which is Easy TCA. They say that is a fantastic pill which has to be freshly prepared for each patient, and that has an excellent result in the melasma treatment. Another pill, TCA pill I use is by Sesderma. So for face, I usually use 25%. Some rare cases, I can go up to 35% TCA pill also. These are the pill I find very safe for Indian patients. This is for TC1. For glycolic acid, my preferred glycolic acid pill is Neostrata. There is a little bit of an availability issues. For Neostrata glycolic, I usually start from 35%, can go up to 50% and even 70% in certain patients. So step by step, I usually increase the percentage. If you do not have a Neostrata glycolic pill, or if you are not confident using glycolic pill, which is a solution based, and you are preferring a gel based, then Sesderma glycolic pill 35% is very good.
Great. So, Dr. Day, we heard about different peels you have been using. How about chemical peels as maintenance therapy in melasma?
Oh yes, so in fact I use peels as a mainstay of my maintenance treatment for melasma. And now, what I already told that QC Gendiac laser is possibly my two-goal laser when I start the treatment of melasma, especially the refractory ones. What I do every 3 weekly, I do QC Gendiac laser in as I mentioned, a laser toning mode for about 8 to 12 sessions at times. Still we get a good results, but once we get a good result, then I usually do chemical peels either with a glycolic acid or a TCA based peel every monthly, and try to maintain whatever improvement I have done already achieved with QC Gendiac laser. So yes, in treatment of melasma, it is one of the mainstay treatment for me.
So, Dr. Day, there are newer, PRP techniques and GFCs which are coming into, melasma. So, do you do PRP for your melasma patients?
Oh yes, last 4-5 years, that has been a radical shift in the understanding of melasma management. Now PRP and of late the GFC, which is basically more of an advanced way of delivering PRP. So those are the things which has really come up well in the management of melasma patient, and I'm seeing very good result with those. Of course, I need to combine. It's not a single modality of treatment, but yes, PRP is a mainstay of treatment. So I would say, there is some amount of data already published with PRP, and there's a very recent Indian data is published with GFC kit. GFC kit is used to deliver PRP with a already added adjuvants, and that's why it has a better results and efficacious results, which I've been using for last couple of years and seeing good result in my melasma patients.
So, how do you choose patients for your PRP treatment for melasma?
See, these are the patients I usually use, patients there are melasma for long period of time, who already has started a lot of treatment, even including peels or laser even. These are the people usually I combine QC laser with PRP. I do PRP every monthly for about 6 sessions, and I continue doing QC for about 8 to 12 sessions, and together I find very good result in most of my melasma patients, especially the refractory melasma, which has been kind of not giving result to most of other modalities.
So, Dr. Day, is there any real difference between PRP and GFC?
The company who market growth factor concentrate, they say that okay, it has a superior yield. They have added some, pre-added activator inside that. Activator used to be added to PRP even before. The problem is we slowly understood that possibly activity is not that required for management of PRP or other functioning of PRP, because our inside our skin there are fibrin and other molecule which activates the PRP itself inside in vivo. So I would say that there are not too many data available which can actually directly head-to-head compare between GFC and PRP. But overall, what I see in my clinical practice, yes, the yield is better. The result is much more consistent with GFC than the conventional PRP mode.
Dr. Day, where do you find GFC as a monotherapy for melasma patients?
The study published by some colleagues from Mumbai, that is almost a monotherapy. But I do not believe in monotherapy of any treatment, not only for GFC but for anything in melasma treatment. See, melasma is by definition multifactorial. A single modality cannot give you adequate results, so it has to always be combined in sunscreen and topical, sometimes oral Tranexamic, sometimes QC laser. So I always combine, and combination give me the best result. I do not rate any treatment in melasma as a monotherapy. I mean, you still need to use your topicals and sunscreens, at least if you not oral Tranexamic acid.
So, Dr. Day, when you talk about GFCs, what is the kind of response you are getting in lasers and GFC in higher skin phototypes?
Now, talking about higher skin phototypes, rather, speech fatigue type 5, what is usually we see either 4 or 5, laser can be sometimes tricky because, if the laser is not of good quality, if you use a laser which is too powerful in a wrong fluences, then sometimes you can land into bad PIH, even post-pneumatic depigmentation. In fact, post-pneumatic depigmentation, as I already mentioned, is possibly one thing I fear more than PIH. However, GFC, you have to understand, is a color-blind one. So it doesn't really matter what skin phototype is. In all skin types, you can choose GFC or PRP for treatment of various conditions, including melasma.
Dr. Day, for mixed melasma, how do you rate GFC?
So this concept of epidermal and dermal and mixed melasma, I do not really think that's really holds true these days. Maybe very fraction of melasma is only epidermal, maybe a very fraction of melasma is only dermal, but most of our clinical practice, I think it's always mixed melasma. And since now we have dermatoscopy, and if you use dermatoscopy rightly, you can see most of the melasma has both epidermal and dermal components. So for me, all melasma are mixed melasma. And of course, mixed melasma, especially the dermal part of the mixed melasma, is very challenging. Now, talking about the treatment of it, again I see that since the epidermal pigment and the dermal blood vessels all have different sort of roles to play in the melasma algorithm, we need to cover entire part of the melasma pathogenesis so that we give good results. So since the melasma pathogenesis is mixed, since the melasma pathology is mixed, we have epidermal dermal combination melasma in most of our cases, our management has to be mixed also. We cannot just only target the epidermal one or only target the dermal one. That's why I am stressing so much about combining all your devices, combining all your modalities, targeting every elements of the pathogenesis. Use Tranexamic to cover your vascular element, use sunscreen to protect against the ultraviolet, use topicals to take care of your epidermal. Use both PRP and of course your QC laser or other lasers to take care of your dermal element, and also this resurfax resurfax lasers to take care of your collagen settle down. So everything has role in a holistic improvement in the patients of melasma.
We wanted to focus more on the current tranexamic acid which has been there. So what kind of doses and how long you have been using tranexamic acid? In what concentrations have you been using tranexamic acid, and how do you rate oral versus topical versus intralesional tranexamic acid?
So if you ask me, then in melasma management, tranexamic acid is possibly the most important game changer. I started using tranexamic acid way back in 2013. I saw that a lot of people in Thailand and other countries like Philippines, they are using tranexamic acid for melasma treatment. You need to understand that point of time only brands are available are gynecological brand,
right.
And our prescription is to be bounced by the pharmacist telling the doctor has written a wrong medicine. So that's how we have moved in the last 10 years almost now in the management of melasma. Now it's part of most of our guidelines for melasma treatment. Now of course you can use topical tranexamic acid, you can use intralesional so-called mesotherapy of tranexamic acid, and also you can use oral tranexamic acid, and there have been head-to-head studies also. However, we need to understand wherever we can give oral tranexamic acid, oral tranexamic has the maximum impact in the management of your melasma patients. But there are certain patients where tranexamic acid orally may not be given. You are scared to give it because of multiple other comorbidities or the multiple other drugs the patient is taking. In those patients, you can try out either intralesional or topical. Intralesional is better than topical, but then it's as a pain of injection. You have to call the patient every 2 weekly. So if you cannot give even intralesional, then topical remains the only modality of treatment. Topical tranexamic acid is available in 10%. Similarly, intralesional can be given in 10%. Now, intralesional, the so-called mesotherapy tranexamic acid is basically, you have to understand, mesotherapy is basically an intradermal injection. Nothing big deal about that. So it's an intradermal injection. So you have to give little below the dermis in multiple shots. So there are two kinds of use of intradermal tranexamic acid. People has given injections, like you can use an insulin syringe to inject on your melasma patches, and people has also used derma roller to have a derma roller done over all of the face, and then use tranexamic acid solution all over the face so that the absorption can happen through all over your face. In my practice, I combine both. I give injections which is on the selective patches also, and also do derma roller all over and kind of spread the solution all over the things. So these are the patients where I cannot give oral tranexamic acid. Whenever I can give oral tranexamic acid, I give 250 mg twice daily. Usually after food. Do remember, tranexamic sometimes can cause gastric irritation. So if your patient needs, you can give pantoprazole or something, antacids, all those things. You can give safely for long period of time. There are studies where you can give up to 21 months also. But in my practice, I usually give for 4 to 6 months at a stretch, and usually by 4 to 6 months I get good results. Sometimes I may have to repeat, maybe next year or year after that, then I give for another 2 to 3 months, so till the disease goes up. But that's how I usually practice using tranexamic acid in my practice.
Dr. Day, with tranexamic acid, do you also suggest your patient certain tests, and there are certain group of patients whom you feel that you shouldn't be giving tranexamic acid in those patients?
Oh yes, of course. So you have to understand, tranexamic acid is a pro-coagulative medicine. So there will be a lot of patients of yours who needs aspirin or some other anticoagulants for their cardiac condition. You do not give tranexamic acid to those patients. This is one. Patient who has irregular period already, you do not give tranexamic acid to those kind of patient. Patient who has a Aplas syndrome or anti-nuclear antibody positivity, patient who can develop some kind of coagulative defect, thromboembolism, history of thromboembolism past, history of recurrent abortion, all those patients you tend to avoid giving tranexamic acid. And yes, I do test in before I give tranexamic acid. Though it's not recommended, still I do platelet, BTCT, APTT, that's routinely. And in certain select patient where I think I should be doing, I also do antinuclear antibody and APLA if I feel the patient's history suggests you have some kind of rheumatological issues.
How you prepare for PRP for melasma, and what are the pros and cons of the procedure?
So preparation of PRP for melasma is similar to preparation of normal PRP for any other procedure, I would say. See, basically there are two ways you can prepare PRP. Once you can use your own vials and stuff for and most likely that is when you do double spin method, or you can use a standard kit which is available. That can be GFC kit also, that can be any other kit also. So that is the two way basically you can prepare. Now, if you use a kit, the delivery is possibly more consistent. And if you use double spin method and you do lot of standardization, even then you can get a very uniform result with your PRP. Do have to remember something, that to get the best kind of result, then you have to hit platelet level which is up to 10 lakhs per milliliter. Below that you do not get good results. So I would always say people who are starting PRP, the very first few patients they do on their own therapist or somebody from their own family and check what the yield of the PRP. Now another important issue which I routinely do before I start PRP or GFC treatment, to do a platelet level. Now you understand that whatever kit you use, double spin method or standard kits, it's unlikely that you get a result which is more than 3-fold of your standard platelet level. 3 to 4-fold, maximum 5-fold you can get. But if somebody's platelet level is already very low, suppose 1.5 lakhs or 1.2 lakhs, there are a lot of patients you do random test, you can see very low level of platelet. These are the people are not good for PRP treatment in my mind, because even if you have 3 to 5-fold increase, then you only reach 5 to 6 lakhs or 10 lakhs, 8 lakhs maximum. But you can never reach to 10 lakhs. So I'll take somebody's platelets which is at least 2.5 to 3 lakhs, and then I can assume that with standardized technique I can develop a very good consistent result with PRP. Then another thing, choosing your patient carefully. People of PRP, whatever kind of you give anesthesia, everything, are little painful PRP procedure. They have to come regularly. So people are very far off places, people who are not very pain sensitive, these are the people may not be good for PRP. So you have to do counseling of the patient very rightly and tell very fast day that these are the things to be expected, and the outcome is only long term. There's no immediate impact after doing the PRP, even if it's expensive, even if it's a lot of pain. And another thing, if the patient has a bleeding disorders, or patients has some kind of immunodeficiencies like uncontrolled diabetes, then also you possibly refrain for treatment with PRP, because then you can land into other kind of infection or bleeding problems.
Thank you so much, Dr. Day. It's been great hearing you, and I'm sure by this we end our series 2 on GFCs and PRPs and the role in melasma. We would be with Dr. Day for the series 3 where we'll talk something different on melasma. Thank you so much.